Good morning, guys. Hopefully this time it's going to work because this is my third attempt at trying to record this talk for you guys. As you can see from my title page, we are going to be talking about dermatoses of pregnancy. The way that I have my slides formatted, we'll do kind of a general introduction, followed by the different diagnoses, and the way that I have it set up is kind of in a benign to riskier dermatologic conditions that can have increased risk to either the mom or the fetus. So without further ado, let's move on. So these dermatologic conditions, it's a heterogeneous group, mostly of pruritic inflammatory dermatologic processes. And these are, we're going to be talking about specifically pertain to pregnancy or immediate postpartum period. Pruritus actually affects about 23% of all pregnancies. So it's not uncommon. You'll probably have patients complain to you about itching, but it's difficult because we don't encounter it that frequently that we feel very comfortable diagnosing these conditions. There's confounding signs, and but it's important to recognize this because for some patients it can actually really be excruciating. And it certainly can decrease their quality of life. So generally speaking, unfortunately, the diagnoses are kind of vague. The treatments are kind of plus minus. Oftentimes, they may reduce some of the symptoms, but quite frequently, it's difficult to completely resolve the symptoms. And of course, the prognosis of the pregnancy is going to be dependent on what exactly the diagnosis is. And then as far as the risk, some conditions we'll talk about actually do have both maternal and fetal health implications. As far as the classification of diseases, the ones that we're going to cover include, again, going from kind of most benign to possibly having the riskiest profile for either mom or fetus is the polymorphic eruption of pregnancy, which was also formerly known as PUP. There's the atopic eruption of pregnancy group. Then we'll touch upon pemphigoid gestationis, pustular psoriasis of pregnancy, and then conclude by the majority of the talk being on intrahepatic cholestasis of pregnancy. So the dividing line for diagnosis, the first question is, are there eruptive skin lesions? Yes or no? So if it's yes, then you can actually probably exclude cholestasis of pregnancy. And if there aren't any discrete eruptive lesions, then you might be facing cholestasis of pregnancy. Most often, you do not need to do skin biopsies. However, there are a couple conditions that we'll talk about. And in those specific diagnoses, although you can make a clinical diagnosis, there are specific findings on histology that could confirm your suspected diagnosis. And just as kind of a little hint, the two that we'll be talking about is pemphigoid gestationis and pustular psoriasis of pregnancy. So moving on to polymorphic eruption of pregnancy, or PEP as I'll call it. Relatively common. We can find it in about 1 in every 160 to 300 pregnancies. More common in the nulliparous patient, and certainly more common in multiple gestations. And you'll see this as a recurring theme on most of these dermatologic conditions, that the more babies you have, the increased risk you have of having some kind of skin condition, which is not uncommon with a lot of the other pregnancy comorbidities. So usually appears in the third trimester. It's extremely itchy and has erythematous papules within the striae. It starts in the abdominal region. However, it's very important to know that it is periumbilical sparing. Not only that, it also spares the face, palms, and soles of the feet. They initially start off as target-like lesions with white halos, but then as the lesions spread and coalesce, it could be more characteristic of what we think of urticarial plaques or hives. So looking at this drawing, you can see that the periumbilical and kind of immediate groin mons area is spared, but it certainly does affect most of the truncal area. And I believe this actually gives a better representation, where on the left you can see that there is that periumbilical sparing. And then you can see that on the right picture that most of these lesions are within the striae of the stretch marks on this patient's abdomen. So it's pretty characteristic as far as the distribution of the rash. There aren't any lab abnormalities, so you certainly don't have to check for anything. And again, there are no specific pathologic or histologic findings, so skin biopsies are not necessary. As far as the mechanism, it's not 100% clear, but the hypothesis is that skin stretching damages the connective tissue and collagen, which in turn then sets off an immunologic response to the skin antigens. So again, that's why you tend to see a lot of the rash happening in the striae of these stretch marks, because that's obviously where the stretching and damage has occurred. And then the other thought is that in these areas of the skin, there could also be these fetal antigens that we all know is within maternal circulation, is also being implanted into the maternal skin and therefore causing an immunologic response as well. As far as treatment, the first line is going to be topical steroids, probably hydrocortisone, although in some severe cases where the topical hydrocortisone low dose is not going to be effective, you certainly may need to increase to higher potency, or you may even need to administer systemic steroids. In addition to that, you certainly can prescribe antihistamines, because one thought is that it is due to kind of an allergic reaction, right? So theoretically, antihistamines should improve their symptoms. And you can counsel the patient that most symptoms will improve within 2 weeks after delivery. Thankfully, there is no proven risk of increased fetal or maternal morbidity or mortality, so there's no indication for an early delivery. Even though the patient may be miserable, there is not an indication for early delivery, as we will discuss in some of the other conditions. As far as recurrence risk, it's kind of vague. Some will say 0% risk of recurrence, and others will say up to 7%. So it's a lower risk, but certainly patients can be counseled that they are maybe at a small risk for recurrence in future pregnancies. Now moving on to the topic of atopic eruptions of pregnancy. These are known to possibly be the same disease process, and in fact, some authorities will actually lump PEP within this spectrum of disease because, again, it's kind of an immunologic / allergic response that's happening. The exact incidence is unknown. However, it probably is the most common skin disorders of pregnancy, affecting up to about 50% of pregnant patients. Again, like PEP, it will primarily present in the third trimester. And this one, typically you can counsel the patients that there is a higher chance that it'll recur in subsequent pregnancies. As far as the pathogenesis, again, it's thought to be an immunologic change. I don't think you need to commit to memory that it probably has to do with the discordant production of Th1 and Th2 cytokines, but just know that there is an immunologic response probably that's responsible for the reaction and for the skin condition. Specifically, talking about prurigo of pregnancy, they're going to typically present as erythematous nodules on the extensor surfaces of the limbs, so legs, wrists, and hands, and trunk, including the abdomen. So the lesions can coalesce into larger groups and may be crusted or eczematous. So this is kind of more of the picture of like a typical atopic dermatitis type of picture. Versus the pruritic folliculitis, these are sterile eruptions of itchy small follicles and pustules, and they're mostly found on the shoulders, upper back, arm, and belly. And they actually can resemble acne. If you look closely, you can kind of see little white heads. So it kind of looks like whitehead acne. And it's pretty characteristic of like, where you would have back acne in the shoulder and the back area. So there's no specific microscopic findings. So again, biopsy is not helpful in the diagnosis of this particular skin condition. As with the other condition, PEP, the treatment is again going to be topical steroids and antihistamines. And similarly, there's no negative maternal or fetal effects. So again, no indication for early delivery. Moving on to pemphigoid gestationis, you're going to see that a lot of these disease entities, for whatever reason, have gone name changes in the recent years. So I put the former names in parentheses because that's what you may be aware of, but I'm putting the actual name that it should be going by now, at least for testing purposes, you should know. So again, on pemphigoid gestationis, the incidence is very rare. It's going to be only 1 in 50,000 pregnancies. It's going to usually begin with urticarial papules and plaques around the umbilicus and extremities. So that's a key differentiating point, right? Because PEP especially is going to be periumbilical sparing, whereas this one is going to be including the umbilical areas. The lesions also do affect the face, palms, and soles. And when they actually get bad, they're going to form bullous lesions. But it's important to realize that at the time of initial presentation, you may not actually see these bullae or blisters. It may just be a complaint of pruritus and papules, but not necessarily forming into bullae quite yet. And the other thing that distinguishes this disease entity compared to the other ones that we spoke about so far is that the mucosal surfaces can also be involved in about 20% of cases. So if you're suspecting this, you certainly should be looking in the patient's mouth also to see if there's any lesions in there. Now this picture, certainly is a more severe case, but it demonstrates, what the bullae could potentially look like. So this one is going to set in the second trimester, so that's kind of a distinguishing factor. But it certainly can also happen in the postpartum period. In fact, 20% of the cases will happen in the postpartum period. And unfortunately, if they have it in early pregnancy, and if you're able to treat it appropriate, unfortunately, they're not completely out of the woods because 75% of them will actually have a flare in the postpartum period. However, generally speaking, at least the initial symptoms should resolve within weeks and months from the delivery time. Recurrence rate, thankfully on the lower end, about 8%, which is similar to PEP. And it may actually provoke patients to have another flare or an episode when they start menstruating or start using oral contraceptives in the postpartum period. And up to 25% of patients will actually experience this. So I think it's important that you counsel the patients so they know what to expect potentially. So, as in the other cases, it really is thought to be an autoimmune disorder. And there's a lot of detail that I put on this slide, but generally speaking, the idea that I want you to come out with is that the autoimmunity appears to start in the placenta. So the important thing is that the chorionic and amniotic epithelia, along with the epidermis, are all of ectodermal origin. And so these binding of antibodies to the antigens at these placental tissue and of the epidermis is basically going to cause an inflammatory cascade that results in separation of the epidermis from the dermis, thus causing the bullous formation. And there's also some thought that there might be a genetic predisposition. Again, I don't know that you need to know exactly which HLA, but there's been an association with specific HLA phenotype, HLA-DR3 and HLA-DR4. So this is one of the skin conditions that you can ask one of your derm colleagues to perform a skin biopsy, because if you see a linear deposit of complement C3 at the basement membrane zone under direct immunofluoroscopy, and this comes from a pregnant patient, then it's essentially pathognomonic for pemphigoid gestationis. So this is one of the situations where getting a firm diagnosis is possible based on the biopsy results. And just so that you guys know, in my reading, I did find that there are commercially available serum tests. I don't know the details of it, but I presume that it's going to be testing for those specific antibodies, and whether it's readily available and what the costs are, I'm not exactly sure. But just know that theoretically there may be less invasive ways to confirm diagnosis instead of having to do a biopsy of the skin. So as far as treatment, this is certainly one that I would consult my derm colleagues because you're going to basically skip the lower potency topical steroids and you're going to go directly to the high potency. And even at that, there's a good chance that they're going to fail this therapy and that they might actually need systemic corticosteroids like prednisone. And of course, as far as the pruritus is concerned, you're still going to want to give them some antihistamines to give them a little bit more of the symptomatic relief. As far as maternal and fetal outcomes, there is a risk of recurrence. But more importantly, as far as the fetus, there is an increased risk of preterm delivery and IUGR. And the mechanism for this is that, remember, we talked about the mechanism of how this disease works as an autoimmune process that where the antibodies attack the placenta. And so when there's this overburden of these antibodies being attached to the placenta, there's a thought that maybe it can cause a component of placental insufficiency. So with that being said, should you initiate testing as far as antenatal testing at the time of diagnosis? So, this is such a rare disease that there's no, clear guideline, but certainly if you ever see a patient like this in all of your career, it wouldn't be wrong for you to get non-stress tests and probably some growth scans to confirm that placental insufficiency hasn't set in. The next entity is pustular psoriasis of pregnancy, which was formerly known as impetigo herpetiformis. This is a very rare condition, even rarer than the than the pemphigoid gestationis that we just talked about. Again, this is going to usually present in the third trimester, but really can occur at any time. And the important distinguishing factor for presentation on this one is that the eruptions usually begin on the flexural areas and spreads centrifugally. So it involves the trunk and extremities. It usually spares the hands and the feet and the face, but this one also can have oral and pharyngeal eruptions. The other distinguishing symptomatology is that pruritus is actually absent, whereas in all the other skin conditions, the primary symptom that patients are probably going to complain about is pruritus. However, these patients may have other systemic symptoms, including malaise, fever, anorexia, nausea, vomiting, etc. So these are obviously bad cases. They look like they're painful. I couldn't actually find anywhere that these are actually painful, but they certainly look like the typical plaques of psoriasis outside of pregnancy, and it looks kind of thickened and very uncomfortable in my opinion. But like I said, I couldn't find anywhere that this is particularly painful to patients. As far as the diagnosis, this one is also another one where you could consider asking your derm colleagues to confirm with a biopsy. And the finding that's pretty consistent would be spongiform pustules with neutrophils in the epidermis. This one, as I had mentioned before, you can find, or the patient can complain of some systemic symptoms, and one of the things that you may see is hypocalcemia. So if you're suspecting this, you should actually check a calcium level and make sure that they're not hypocalcemic. As far as the fetal outcome, similar to gestationis or pemphigoid gestationis, there is a risk of stillbirth, IUGR, and miscarriage. And again, it's because it's thought to be more of a placental insufficiency type of picture than it is more of anything else. So, getting antenatal testing. Certainly correcting and monitoring hypocalcemia in the mom, and even considering early delivery are considerations. The other thing to again note is that these, although the skin lesions themselves aren't necessarily infective, certainly they can get a superseded bacterial infection. So you clearly want to, examine the patient and give them precautions as to what to look for to make sure that there's not a superseding bacterial skin infection. So again, as far as treatments, this time you're essentially going to skip all the topical stuff and you're going to go straight to high-dose systemic steroids. And there is some literature that maybe IV cyclosporine may be an adjunctive medication, but certainly this is something that I would not feel comfortable treating. I would definitely get a derm consult. So the main topic that I wanted to get to, because this is the one that you're going to see most often on labor and delivery or in the office while you're taking care of your prenatal patients, is intrahepatic cholestasis of pregnancy. So what causes this? Well, nothing is 100%, but there's 3 suppositions, one of which is genetic factors, another one environmental, and the last one is hormonal. So touching upon the genetic susceptibility, they see studies can show that there's certainly familial clustering. There's increased risk in first-degree relatives, increased risk in some ethnic groups, and certainly a high percentage, very high, 60 to 70% recurrence rate. So unfortunately, patients who have it once, you can basically counsel them that most likely they're going to get it in the subsequent pregnancies. There's also environmental factors. So studies from, I believe, Sweden, Chile, and Finland have shown that there's certainly seasonal and geographic variability to when cholestasis of pregnancy occurs. And they also noted that decreased levels of selenium and vitamin D can also be associated with increased chance of developing cholestasis of pregnancy. And lastly, hormonal factors. It's been postulated that both estrogen and progesterone may play a part. I'm more convinced of the estrogen and the fact that multiple gestations have an increased risk, and also the fact that women who have gone through ovarian hyperstimulation as part of their assisted reproductive technologies can actually get cholestasis of pregnancy very early on in pregnancy. And then also the fact that a lot of the symptoms will resolve shortly after delivery once you remove the placenta. Now, as far as the progesterone, in some genetically predisposed women, the formation of large amounts of sulfated progesterone metabolites may result in the saturation of hepatic transport systems utilized for biliary excretion. So essentially what that's saying is that because of all these metabolites that build up, the biliary excretion system basically gets overloaded and is not able to excrete the bile like it's normally supposed to. And so therefore there is a buildup of the bile acids. The incidence is quite varying depending on the population. It's as low as 0.1% and as high as 27.6%, with that being in the Aracanos Indians of Chile. Again, I had mentioned that there's an increased incidence in the winter months, shown in studies that were done in Chile, Sweden, and Finland. And then, of course, there's increased risk in multiple gestations, higher in twins and significantly higher in triplets, and I'm sure in higher order multiples even higher. So we've seen this in clinical presentation where patients will report intractable itching, but you don't actually see any eruptions or actual rash. What you see are excoriations due to the scratching. It's most notable on the palms and soles of the feet. It's kind of pathognomonic when they say that their hands, the palms of their hands and the soles of their feet are itchy and usually worse at night. Again, this is typical to present in the third trimester, but as we talked about in patients who have gone through ovarian hyperstimulation, you can actually see it as early as the first trimester. And some of the other symptoms that patients may complain about are right upper quadrant pain, nausea, poor appetite, certainly sleep deprivation, because a lot of them are going to be so itchy overnight that they're just up all night scratching themselves. And then steatorrhea may actually also appear, and we'll talk about that a little bit as to why that can occur. So the hallmark of the diagnosis, as you all know, is going to be elevated serum bile acids. I think it is reasonable for you guys to know that we do get a total bile acid, but the main component that we're checking for that makes the majority of the total bile acids is cholic acid. So I think it would be good for you guys to remember that it is cholic acid. Greater than 90% will have an increase in the serum total bile acid concentration. It is preferable that you draw them in a fasting state, but not required. And as you know, anything greater than 10 micromoles per liter is diagnostic for cholestasis. Now, previously, greater than 40 was kind of consistent with what was considered to be severe disease. There's more evidence potentially that is coming out that is pointing to maybe it's actually not as severe as we thought, greater than 40, and it's not until you actually reach about 100 micromoles that it's considered to be a severe form of the disease. In order to Risk stratified patients, you may need to get serial measurements to show the rise in bile acids. So, i.e., at the time of diagnosis, they may be 30, right? But throughout their pregnancy, despite being on medications, um, somebody who's got severe disease may continually increase their bile acids. And if they go up to 100, then now they are now considered high risk. So there is some utility in getting some serial bile acids if they're diagnosed early enough. And as you've probably seen, sometimes before and sometimes after the elevation of the bile acids, you'll concomitantly see that there's an increase in LFTs. Very typical that it's not going to be greater than 2 times the upper limit of normal, but it's going to be a mild elevation. And this is the next point is where I want to talk a little bit about the steatorrhea. That happens because typically the flow of bile is that it's created in the gallbladder and then it gets transported through the duodenum, which is a lot of where the fat soluble vitamins and fat is absorbed. However, if there's a blockage for whatever reason, whether that be iatrogenic because you're giving them medications or because the initial pathologic dysfunction of the bile acids not being appropriately transported, basically when you don't have bile acid in your duodenum, you're not going to be able to absorb the fat. And so essentially you're creating a situation where there's fat malabsorption, which is then going to lead to steatorrhea. Now, I personally haven't really seen that, but at the same time, it's not like we really check for it in all patients. I would assume that this is going to be more applicable to the severe diseases, or if a patient actually, complains of having very fatty stools, then you can certainly check for their vitamin K and some other of their fat-soluble vitamin micronutrient levels. And as far as a liver ultrasound, unless you have suspicion that she has other liver pathology or has concomitant, preeclampsia/HELP, really a liver ultrasound is not going to help you. As far as maternal outcomes, for the mom, it's generally harmless. Don't discount their symptoms because certainly some patients are absolutely miserable, but you can counsel them that oftentimes the symptoms will resolve after delivery and or earlier with appropriate medical therapy. There is no known hepatic sequelae, but you do want to, again, consider checking for fat-soluble vitamin deficiencies in patients who potentially have the more severe form of the disease. And like I said previously, unfortunately, once they have it, they're at a high risk of having it in their subsequent pregnancies. So, fetal outcome, we know that the morbidity comes with the fact that maternal bile acids cross the placenta and can accumulate in the fetal compartment. So when that happens, it can affect basically many different organ systems in the fetus. But the study that I am referring to is the one that I sent out to you guys, showed that there's an increased risk of meconium-stained fluid, increased risk of prematurity, and granted, a lot of that prematurity is going to be more iatrogenic than spontaneous, but there's also increased risk of respiratory distress, and that is postulated to be because of the bile acids actually entering the fetal lungs. And then with all those complications, of course, comes with the increased NICU admission rate. As far as the IUFD risk, it is thought that it is a sudden development of either a fetal arrhythmia or vasospasm of the placenta-chorionic surface vessels that is due to the high levels of the bile acids. So again, of course, you have to exclude all the other attributable causes like preeclampsia, diabetes, IUGR, and fetal anomalies. But the main difference that I want you guys to take home between this cause of IUFD versus that of pemphigoid gestationis and pustular psoriasis of pregnancy is that, you know, you can have a completely reassuring non-stress test and then end up with an IUFD couple hours, you know, after, because again, it's not like a developing placental insufficiency picture where you can see, you know, a development of the pathology occurring. Unfortunately, you can have a very reassuring non-stress test or BPP because it's not indicative of when the sudden acute event is going to occur. So with that being said, this paper was one of the ones to show where maybe the risk of IUFD is not as high as we previously thought. So they found a 0.9% risk of IUFD versus 0.9% in patients with cholestasis of pregnancy versus a 0.32% in those without. Now, the risk significantly increased when the bile acids were greater than 100, and at that point, the risk became 3 to 4%. So again, that is the reason why some authorities will recommend that you actually get serial lab values, because you're going to counsel the patient and risk stratify them based on the highest value and not necessarily the most recent value. As far as treatment, the goal is to reduce maternal symptoms. And you can certainly treat these patients empirically because, as you know, in 90% of the patients, you're going to actually see the laboratory abnormalities as far as the increased bile acids. In some patients, they meet all criteria by symptomatology, but you just may never actually get the elevation in liver acids or bile acids or the elevation in the LFTs. And as you know, the mainstay of treatment is ursodiol. It's important to let your patients know that this medicine doesn't work immediately, that it often takes up to 1 to 2 weeks for the symptoms to improve as far as the pruritus, and that labs may not normalize ever, but if it's going to take at least 3 to 4 weeks of therapy. However, it is reassuring that as long as they do use the medication appropriately, 42 patients actually do report complete resolution of pruritus, and 61 will at least report some improvement. There's no negative fetal effects when it comes to ursodiol, and side-by-side comparison of dexamethasone versus ursodiol showed that ursodiol is certainly better than dexamethasone and cholestyramine, in addition to antihistamine. So that's why, you know, the first line of therapy is ursodiol. You guys probably know better than me that dosing is you start at 300 milligrams BID to TID, but there's actually quite a bit of wiggle room because you could titrate up to a maximum of 21 milligrams per kilogram per day. And like I had mentioned before, you titrate the medication based on symptomatic relief and not necessarily laboratory improvements. So just to quickly mention, you know, if patients have been maxed out on their ursodiol and still remain symptomatic, you can consider adding something like SAM-E or cholestyramine or rifampin. I'm not going to go into the details, but you know, you can read that they're the mechanisms of how they think it actually works. And like I had mentioned, dexamethasone is less effective than ursodiol by itself, but certainly it can be used as adjunctive therapy in addition to the ursodiol. And then a quick note on the antihistamines. It's not effective generally, and that's because the itching is resulting from bile acids being deposited into the skin and not because it's a histamine release from mast cells. So, you can certainly try, but it's most likely not going to help it. That's why Benadryl hardly ever will work, but the reason why we stick to Atarax is not because it's a better antihistamine, but it's because it actually has a CNS depressant property to it. And so, maybe it helps them to sleep a little bit better, or the decrease in CNS activity just helps it so that the symptoms become a little bit less aware of the symptomatology. Not sure, but we do certainly prescribe Atarax a lot more than any other antihistamine when we are suspecting cholestasis. So, knowing what we talked about as far as what we think causes this stillborn or stillbirths, is there any value in testing, doing antepartum testing? Well, we don't know. But at the same time, we don't know that it causes harm either. So, I think it's important to counsel patients that, yes, we are going to initiate antepartum testing, but again, it's not a chronic placental vascular process. It's going to be an acute process. So, though it is reassuring in some senses if, there's a reassuring non-stress test, but that's certainly no guarantee that an acute event still can't happen. So with that being said, there's no clear guideline as to what is appropriate as far as what exam or frequency. So whether that be, non-stress tests or modified BPPs or BPPs, and if you should do it on a weekly basis or twice weekly, that is certainly up to the providers. I can tell you, for us, we usually do once weekly NSTs until delivery, from the time of diagnosis until delivery. The timing of delivery used to be a little bit more controversial, but I feel like it's a little less now that ACOG has actually come out with in their bulletin for late preterm medically indicated deliveries, where they have actually added cholestasis of pregnancy. But just to let you know, up-to-date authors recommend 36 to 36 and 7. Royal College of OB-Gyn recommends anytime after 37 weeks. And SMFM, I thought that maybe they would change their recommendations after ACOG came out with their bulletin, but I just checked again right before this presentation, and they still recommend between 37 and 38 weeks or sooner with documented pulmonary maturity. I think that's a little ridiculous because none of you, I'm sure, during your training has ever seen us doing an amniocentesis to document pulmonary maturity. That's really gone out of favor. We used to do that pretty frequently when I was a resident, but now that's pretty much not done ever. But ACOG clearly came out with their recommendation of saying 36 to 37 weeks was the appropriate time period to deliver cholestasis patients. And in what situations would you consider even delivering them sooner, right? So certainly if their total bile acids are greater than 100 micromoles per liter, you can consider it. If they've had a history of a fetal demise before 36 weeks, that's attributable to cholestasis of pregnancy, or if their liver enzymes have gotten so bad that they're now jaundice, or, based on maternal symptoms, that they're just absolutely miserable. It's decreasing their quality of life. They're starting to get depressed because of it. You'd certainly have to take that into consideration also. So in conclusion, I know we talked about a lot of entities, but generally speaking, Itching is very nonspecific, and can, imply the presence of a various number of dermatologic conditions. But for the most part, I think you can be reassured that though very, it can be very uncomfortable for the patient, most of them are going to be benign processes. And the ones that are potentially more dangerous, either to mom or fetus, are much rarer. Minus the cholestasis of pregnancy. But those are the ones that you should certainly recognize as far as cholestasis of pregnancy, pemphigoid gestationis, and pustular psoriasis of pregnancy. The ones that have potential poor obstetrical outcome, either to the baby or to the mother. So bullet point to take home, most are benign. The ones to remember are pemphigoid gestationis, pustular psoriasis of pregnancy, and intrahepatic cholestasis of pregnancy. Pustular psoriasis of pregnancy, you actually don't have the pruritus, versus pretty much everything else. One of the presenting symptoms is pruritus. Hypocalcemia can be found in pustular psoriasis of pregnancy. And you only really want to get biopsies when it comes to the pemphigoid gestationis and pustular psoriasis of pregnancy. The rest of them really should be clinical diagnoses, and there's no pathognomonic findings on histology. So spare the patient from getting a skin biopsy. That concludes the presentation. I hope you guys learned something. Definitely feel free to email me or contact me otherwise if you have any questions, and I will certainly do my best to answer. That's it. I hope you guys are healthy and stay safe, and we'll see you around. Thank you.